Good afternoon to everyone and welcome. From Medicine Unit 3, we are presenting an interesting case today, an uncommon cause of shock in the medicine ward. Dr. Satang and Dr. Tariq will present the case and Dr. Ranveer will moderate. Thank you.
So, good afternoon, everyone. I am Shutang, a junior resident from Department of Medicine. I will be presenting today's case. So, starting with the demographics, our patient was 20-year-old male, resident of Delhi. Patient had a history of corrosive injury back in March 2020, for which patient was on feeding jejunostone. Patient presented to us on 3rd March 2023 to emergency with the chief complaints of diarrhea, for 10 to 15 episodes per day, water inconsistency for past 2 weeks, fever intermittent without any chills and rigor for past 3 days, and decreased sensorium in form of decreased verbal output for past 2 days. In the past, patient had history of bipolar disorder for which he was under psychiatric follow-up, and as described before, had a history of intentional corrosive ingestion in March 2020. Patient was receiving his feed in the form of homemade FJ feed every 2 hourly. Patient's family history was not significant. Coming to the general examination, on general examination, patient appeared to be undernourished and had significant pallor. His pulse rate was 90 beats per minute. His BP was 96/55 on the lower side. His respiratory rate was slightly increased, 24 per minute. His room air saturation was only 81% and sensorium was low, with GCS being only E2, V1, M5. Coming to systemic examination, on respiratory examination, patient had right infrascapular coarse inspiratory crepitations and patient was not oriented to time, place and person. The rest of the CVS examination and abdominal examination were normal. At presentation only, in view of poor sensorium and type 1 respiratory failure, patient was intubated. And as we can see in the chest X-ray, chest radiograph, patient had bilateral opacities, right more than left. Coming to investigation, as we can see, patient had severe anemia of 6.8, which can be attributed to iron deficiency anemia, as transfusion saturation was just 11.7%, and anemia of chronic disease, as ferritin was high. Also, patient had neutrophilic leukocytosis and low platelets, which can be attributed to sepsis secondary to LRTI. So the initial impression of the patient was persistent gastroenteritis with lower respiratory tract infection, with sepsis, with septic encephalopathy, with anemia, with a history of corrosive injury and bipolar disorder. On the basis of this, patient was given initially IV fluids to bring the BP up and was given IV antibiotics empirically, peptaz and azithromycin for LRTI, and was transfused 1 unit PRBC in view of severe anemia. The persistent gastroenteritis of the patient was postulated to be secondary to increased frequency of FJ feeds, and hence the FJ feeds were stopped and TPN was started for the meanwhile. With the following treatment, gradually over the days, patient's sensorium improved and became E4 VT M6, BP became normal, and FiO2 requirement came down to 21%. Then on 7th March 2023, in ward early mornings, patient self-extubated. Following self-extubation, patient was kept on HFNC, on which patient started accumulating CO2. For that, patient was then shifted to NIV. Despite being on NIV, patient kept on accumulating CO2, and in the view of worsening type 2 respiratory failure, patient has to be reintubated by the evening of the same day. Few hours after reintubation, patient was noted to have swelling over chest and neck, which had palpable crepitations, on palpation. And as we can see in the follow-up chest X-ray, there is air present in the subcutaneous tissue, here and here, confirming the diagnosis of subcutaneous emphysema. So, summarizing the case till now, patient presented to us on 3 March with persistent diarrhea and LRTI-related sepsis, for which initially he had to be intubated and was given IV antibiotics and fluid. With this treatment, patient gradually improved, and on the 7th March early morning, patient self-extubated. He couldn't maintain at room air, so had to be intubated again. And post-reintubation, patient developed subcutaneous emphysema. After reintubation, patient was shifted to ICU for close monitoring. From 8th to 10th March, patient condition remained stable. Then, on 11th March 2023, patient suddenly developed shock. His BP became 26 by 62 millimeter of Hg. Heart rate increased to 144 per minute. Respiratory rate increased to 34 minutes. Saturation remained at 97% in the following ventilatory settings. Comparing the investigations of the day when patient developed shock to the day before, we can see the TLC was on decreasing pattern and platelets were increasing, which is suggestive of improvement in the sepsis component. Also, there was a component of pre-renal AKI before, which also was improving. There was no new onset organ dysfunction. So let's evaluate what could have been the cause of shock in this patient. So starting with hypovolemic causes. So just the day before the shock, patient had input of around 4 liter and output of 1.5 liter. This excess input was because of the fluids being given in view of pre-renal AKI. Other than that, patient didn't have any evidence of bleed or any new onset diarrhea or vomiting. Though IVC couldn't be assessed because of the subcutaneous emphysema, we couldn't do POCUS. So we can see the hypovolemic cause is very less likely. Coming to the distributive causes, patient didn't have any evidence of anaphylaxis and the markers of sepsis were on improving pattern. Patient didn't have any fever, the TLC was on decreasing pattern, FiO2 was minimal 21% and there was new onset organ dysfunction. Also, since patient was bedridden, chances of patient to have a spinal trauma leading to neurogenic shock was also minimal. Hence, the distributive cause was also less likely. Now, coming to cardiogenic causes, patient didn't have any known cardiac disease and given his age and patient was not on any inotropic support. So chances of patient to have a coronary event were also very less likely. ECG done at the time of the shock only showed sinus tachycardia. Though we couldn't visualize the heart with focus again because of extensive subcutaneous emphysema. So we can't completely rule out cardiogenic causes. Coming to the obstructive causes, the common causes of obstructive shock noticed in our wards are tension pneumothorax, cardiac tamponade, massive pulmonary edema, and high PEEP ventilation. As shown in the slide before, patient PEEP was just 5, which is not high PEEP, so this can't be the cause. Coming to these 3 causes, normally, especially in ICU setting, we often utilize bedside ultrasound to differentiate between these 3. For example, in tension pneumothorax, we may get a barcode sign. In cardiac tamponade, we may have a diastolic collapse of RA-RV. And in massive pulmonary embolism, we may have a dilation of RA and RV. These also can't be done because of extensive subcutaneous emphysema. For looking for further clues, we evaluated the chest X-ray where we couldn't find any evidence of pneumothorax. But comparing it to the day when the patient presented to us, we can notice the transverse diameter of heart appears to be increased. And also the cardiac Silhouette, which is quite steep here, appears to have flattened. And also we can notice a abnormal radiolucency here and little bit of hair compared to previous X-ray. The combination of these 2 signs is commonly known as earth hurt sign, which is seen in tension pneumomediastinum. In tension pneumomediastinum, basically there is extensive air inside the mediastinum, causing which puts pressure on the heart, changing its shape. So, in view of repeated history of twice intubation, which may lead to tracheal injury, the presence of earth hurt sign in chest radiograph, and presence of subcutaneous emphysema with shock, we suspected tension pneumomediastinum to be the cause of the shock, and a CCT chest was planned. Now, I will like to call Damini ma'am from Radiology to comment on it.
Good afternoon, everybody. So CCT chest was done on 11th of March 2023. And as we can see that there was extensive pneumomediastinum with compression of the anterior border of heart. We can see that there is flattening of the anterior border. As well as in this, we can see that there are some linear hypodense lucencies radiating from the pulmonary interstitium towards the mediastinum, which could represent the Macklin effect and the barotrauma, causing a pulmonary interstitial emphysema and leading to pneumomediastinum and extensive subcutaneous emphysema, even reaching the scalp and bilateral shoulders. There was minimal amount of pneumothorax as well, which was loculated. And because of the extensive pneumomediastinum and compression on the heart, we can also see that there is dependent areas of consolidation and ground glassing, maybe because of the reduced diastolic return, diastolic filling of the heart and reduced central venous return. Continuing with the CT scan, so we can see that the trachea is also compressed by the extensive pneumomediastinum. Apart from that, there were signs of active infection seen as cavitating nodule with surrounding consolidation. And we can also see that the pneumomediastinum was so extensive that air has also extended into the extradural space of the spinal canal, which is known as pneumorachis. And this can also lead to neurological compromise. But in this case, it's very rare. And in this case, we cannot evaluate for neurological compromise because patient was in altered sensorium already.
So on the basis of these findings, we consulted CTVS department, and they advised placement of bilateral ICD and a pigtail in mediastinum. Despite putting bilateral ICD, there was no improvement in shock of the patient. So we decided to go ahead with the pigtail placement in mediastinum.
So based on the clinical and CT findings of tension pneumothorax, and there was failure of improvement in the obstructive shock after the placement of bilateral ICD. So we went on with CT guided parasternal drainage for the pneumomediastinum. So there are two main points to remember in this is that we need to place the puncture site lateral to the sternal midline. So we can see that the puncture site is lateral so that we avoid the internal mammary vessels, which can be seen here. These are the internal mammary vessels. And the second point is to angulate it medially in order to avoid injury to the lung. So we choose a puncture site in the second intercostal space lateral to the sternum under CT guidance, sparing the internal mammary vessels and medially angulating it, and we place the mediastinal drainage. Now just reviewing the x-rays, the 3rd March when we had just infective etiology with LRTI, there was no signs of any subcutaneous emphysema and the heart was tubular. And on 8th March, after intubation and positive pressure ventilation, we can see that there is extensive subcutaneous emphysema, which itself is an indirect sign of probably barotrauma leading to pneumomediastinum and then subsequently into subcutaneous emphysema. We can also see that there are linear lucencies along the hilum bilaterally radiating towards the hilum. So this can represent the pulmonary interstitial emphysema. We can also see a lucent line around the ascending aorta as well as a lucent air column separating the diaphragm from the pleura. So all of this points towards pneumomediastinum. Apart from that, as we can see here in the parasternal shadow, paratracheal shadow, we can see that there is lucency now along the medial border of the carotid artery. So we can see both the borders of the carotid artery. Laterally, it is normally outlined by the lung, but here medially, because of the pneumomediastinum, we can see the medial border as well. This is known as tubular artery sign. So based on all of these findings, and apart from that, we also had the increased transverse diameter as compared to the 3rd March and continuous diaphragm sign, we can make a diagnosis of pneumomediastinum leading to subcutaneous emphysema. And post the drainage, so on 13th, we place the mediastinal pigtail, which can be seen here. And post the drainage, we can see that there is extensive resolvement of the pneumomediastinum and the heart shape has also resolved and come back to its normal tubular shape.
Thank you, ma'am. So after that, patient shocks resolved. And in view of prolonged intubation and difficult weaning, later patient has to be tracheostomized and then shifted to ward, and then patient finally got discharged on 13th May 2023. So the final diagnosis was secondary tension pneumomediastinum with obstructive shock, with subcutaneous emphysema, with persistent osmotic diarrhea, with aspiration pneumonia, with sepsis, with septic encephalopathy, with anemia, with a history of corrosive injury and a bipolar disorder. Now I will like to call Dr. Tariq sir for discussion on the topic.
Thank you, Dr. Shweta, for walking us through this case. And good afternoon, everyone. I'm Dr. Tariq, Senior Resident Medicine. So I'll be discussing about pneumomediastinum today. So we will be discussing the topic first by looking at the etiologies of shock, followed by the basics, epidemiology, clinical features, diagnosis, and management of pneumomediastinum, especially focusing on our case, that is tension pneumomediastinum. Now coming to the etiologies of shock, as we know, the most common cause in the emergency is distributive shock, which is present in around 70% of the cases, followed by hypovolemic and the cardiogenic causes, and obstructive causes account for a mere 0.6% of the causes of shock. And like Shwetan mentioned, these are the different causes of the obstructive shock, like tension pneumothorax, high PEEP ventilation, massive pulmonary embolism, pericardial tamponade, and aortic dissection. And a very small portion can be caused by tension pneumomediastinum. Now, before discussing about pneumomediastinum, the mediastinum is the structure which is present between the thoracic inlet above and the diaphragm below, and it is surrounded by the mediastinal pleura. And pneumomediastinum is defined as air that is present in the mediastinum, and also it is known as the mediastinal emphysema, and it develops when the air extravasates from within the airway or lungs and migrates into the mediastinal space. And the extravasated air then may dissect into the cervical subcutaneous tissues, causing subcutaneous emphysema or pericardial emphysema or pneumoperitoneum as well. Now, coming to the classification, just like pneumothorax, pneumomediastinum can be classified on the basis of a direct causative factor and underlying lung diseases. If causative factors or underlying lung diseases are not present, we call it a spontaneous pneumomediastinum, and the risk factors for that are tobacco use, recreational drug use like marijuana and amphetamine. And secondary pneumomediastinum is caused by iatrogenic reasons like intubation, endoscopic procedures, barotrauma from mechanical ventilation, or central venous vascular accesses. And in our patient, intubation and barotrauma were the risk factors which probably led to this. And apart from that, there can be surgical causes like trauma, blunt, blast or penetrating trauma, and non-traumatic causes usually constitute the obstructive lung diseases like COPD, asthma, or bronchiectasis. Now, coming to the epidemiology, it is very uncommon, and the reported incidence is less than 1 in 44,000 adults, and 76% of these patients are males with an average age between 21 to 27 years, and they are mostly benign and resolve on its own. So this is for pneumomediastinum. Whereas tension pneumomediastinum, there is either a airway or a vessel compromise leading to circulatory or respiratory compromise. Now, coming to our experience in our department, where total of 8,294 COVID-19 patients were studied, and out of which only 29 patients, that is 0.34% of the patients, had pneumomediastinum, and 13 of them had concomitant pneumothorax. However, not even a single case of tension pneumomediastinum was reported in this study. Now, we look for the literature in the world literature. We can only find some case series and case reports. This was a case series published from the Middle East, where in an institution around 1,100 patients of COVID-19 were admitted, and 3.9% had a spontaneous pneumothorax and pneumomediastinum, and out of them, only 5, that is 0.45%, had a tension pneumomediastinum. And also, case reports have been there in COVID-19 patients and patients who were taking opioid inhalation. And it is important to note that because of COVID-19, the rates of mechanical ventilation had increased, and at that time we had seen some cases. So it is a very uncommon cause of shock in the medicine ward especially. Now, coming to the pathophysiology, the most common cause of pneumomediastinum is an alveolar rupture, secondary to the increased intraalveolar pressure. This increased intraalveolar pressure can be due to exertional activities like coughing, vomiting, or strenuous exercise, or obstructive airway diseases leading to baseline increase in the intraalveolar pressures, or forceful inhalation of illicit drugs. Now, Macklin described this effect in 3 stages. That is, due to increase in the intraalveolar pressures, the air gets out, the alveoli ruptures, and this air trickles or dissects through the peribronchial and the perivascular sheath, and ultimately it reaches the mediastinum, causing the pneumomediastinum. And this air, when it becomes, when it causes obstruction in the heart and leading to decreased end diastolic volume, it can lead to obstructive shock and cause tension pneumomediastinum. Now, in this case series, we had seen that the most frequent symptoms of the patients with pneumomediastinum was chest pain, which was occurring in around 75% of the cases, followed by dyspnea, which was present in around 49% of the patients. And the chest pain is usually acute, sudden, and retrosternal, and radiating to the neck and shoulder. Now, coming to the physical signs, subcutaneous emphysema is the most common physical sign that is visible. It is usually seen in around 70 to 90% of the cases. And apart from that, we can hear sometimes a mediastinal crunch, which is synchronous with the heart sound, and oscal rupture, especially where a V is formed by a radiolucency present between the descending aorta and the left dome of the diaphragm. Now, coming to the role of other investigations, So radiograph is 90% sensitive in detecting pneumomediastinum, but we might require a CT chest with or without an CT abdomen in high suspicion cases where the chest radiograph is inconclusive, or to identify the causative factors, or when extensive subcutaneous emphysema is present, to rule out concomitant pneumothorax as they are frequently present, and to differentiate the pneumomediastinum from the pneumopericardium, because pneumopericardium has a worse prognosis. Now, coming to CT scan with oral contrast, this is performed when we have a suspicion of a patient having esophageal rupture. So these patients usually present with dysphagia, vomiting, pleural effusion, signs of infection, or hemodynamic instability and pneumoperitoneum. And if these are present, then we might want to rule out esophageal injury with a CT scan with oral contrast. Now, coming to the management part, so if it is a spontaneous one, like we said, we can do only conservative management with hospitalization, bed rest, analgesics, and follow up on OPD basis. But patients who are on ventilator need to be managed very conservatively, need to be managed with precaution, where we should use small tidal volumes of 6 ml per kg, and in high risk settings, especially in like asthma, ARDS, obstructive airway disease, or high PEEP, and when patients require minute volume of more than 12 to 15 liters. In these patients, for prevention as well as management, we need to keep the tidal volumes low, as well as we should keep the plateau pressures as low as possible, especially less than 30 centimeters of water. And we should use PEEP cautiously in patients who have increased risk of alveolar rupture, like patients who have structural lung diseases like nosocomial pneumonia, necrotizing pneumonia. And we should avoid hyperventilation and consider permissive hypercapnia in these patients unless contraindicated. And we should monitor all ventilated patients for auto PEEP or intrinsic PEEP to decrease the barotrauma or volute trauma. And that is done by lowering the respiratory rate or tidal volume, decreasing the IE ratio, or treating the underlying airflow obstruction. And we should wean all patients on mechanical ventilation from positive pressure ventilation as rapidly as possible. Now, management is similar in terms as prevention. And in cases where there is asynchrony leading to elevated pressures, we might want to increase the sedation. And we can also try denitrogenating the mediastinal space by giving 100% FiO2, because oxygen is much more soluble than nitrogen, and that leads to faster resolution of the pneumomediastinum. Now, coming to the role of intercostal drainage, which was put in our patient. So if there is significant pneumothorax associated with the pneumomediastinum, then ICD insertion may be considered. And but we must also remember that ICD being put for pneumothorax may also lead to iatrogenic subcutaneous emphysema. And now this was about pneumomediastinum. If there is suspicion of tension pneumomediastinum, then we need to manage very aggressively. So the techniques that have been applied are, one is Gill's technique, where we put 2 incisions over the supraclavicular area bilaterally to relieve the pressure and drainage of the air. And like in our case, we can put a mediastinal pigtail drainage or an mediastinal ICD drainage for some patients. Now, in patients who do not respond to these therapies, might require surgical intervention such as thoracotomy or sternotomy. And if recurrence of pneumomediastinum occurs, then it can be due to pulmonary or airway pathologies, and those should be ruled out. And predisposing conditions like asthma, COPD, or recurrent vomiting, they should be managed. And if any patient has pneumomediastinum at any point in their lifetime, they should be barred from doing strenuous exercise and scuba diving, as they are absolutely contraindicated. So from today's case, we learned that tension pneumomediastinum is a very uncommon cause of shock and respiratory failure. And chest radiograph is diagnostic in 90% of the cases, and the rest may require CT scan. In majority of the pneumomediastinal organ injury is present, and management can be conservative. But in case of tension pneumomediastinum, we should manage aggressively, like we discussed. And ventilatory management should minimize the barotrauma. Thank you. I would like to call Dr. Ranveer Singh Jadon, sir, for his comment.
So thank you, Tariq. So as we have seen in this case, this case was in very bad shape due to the post-corrosive injury status and presented with the osmotic diarrhea and the lower respiratory tract infections. So this patient was being managed in the ward with the supportive treatment and with mechanical ventilation. So in ward, patient developed the acute onset obstructive shock. So the reason behind the presenting this case in this forum is the rarity of the condition. So obstructive shock is the uncommon condition, and the tension pneumomediastinum as a cause of obstructive shock is the further rare thing. So in addition to this, there are few learning things with this case. So one is although unfortunate, this patient developed the barotrauma. So the barotrauma is the non-complication of the patient who are mechanical ventilation. So in this case, although the ventilator settings were not odd, but there are risk factors. The patient was the undernourished and the patient have the lower respiratory tract infections. So these are the predisposing conditions. So we should be more aware about the ventilator settings as well as the many clinical manifestations of the barotrauma. Second thing is the diagnosis of the tension pneumomediastinum. So simple X-ray film is important to diagnose. So this is maybe the diagnostic in most of the cases, but we need to do the CT if required. Third thing is the management. Because the tension pneumomediastinum has the fatal outcome if the mediastinal decompression is not done promptly. So with this, I would like to thank to the Department of the Radiodiagnosis and Intervention Radiology, Surgery and CTVS Surgery for their help in the management of this patient. So with this, I would like to open the house for the questions and comment. So Dr. Survi, please.
It's a rare condition. We usually see pneumothorax. That's not a tension pneumothorax, in which case mostly conservative management is enough for making sure that the patient is back to his feet as soon as possible. But in this case, this was a rare case. The difficulties that were encountered with this patient was that CT guidance was absolutely essential because there were two things that we had to say. One was the internal mammary artery. The other thing was that the pleura should not also be breached. So CT guidance was essential. Normally for pericardial drainages and mediastinal drainages also, ultrasonography can be employed, but because there was extensive air which would preclude the visualization of the underlying mediastinal structures, CT guidance was like absolutely essential to make sure that we are at the right place to drain the amount of air that is located.
So any more questions and comments? Sir, Rajan Prasad, sir, please.
Just sigh. It's not easy.
Yeah.
Not easy. I mean, like, because many a times we see X-ray, you see a bit of lucency here, lucency there. Yes. It can be very difficult. So I think you need a trained eye to pick it up. And if you picked it up and I think manage very well. And if you have you need to drain it. CT guided fingers definitely available on it. I would say very well done.
Thank you, sir. Thank you, sir. Okay, if there are no more questions. Yes, sir. Yes, sir. Please. Okay.
The decision for doing a CT scan was very important.
Yeah.
Subcutaneous emphysema, the first diagnosis would be here is coming to the tissue. It has to come from the lungs. It is coming outside or coming inside. That is, the CT scan will be much better. That is okay. But when air is coming to the cutaneous tissue, it has to come from the lungs or from the esophagus. And when it's coming to the tissue, so the first scan would have been a CT scan, and within 2 minutes you can make the diagnosis. There doesn't need any big rocket science to see the CT scan mediastinum getting compressed.
So we get many cases of subcutaneous emphysema, but this is the first case of
pneumomediastinum. Extremely rare, but the first, what I'm trying to be conventional conventional radiology, is as teacher, we also feeling the conventional radiology time spent earlier is CT scan, Corley B line, Corley A line, all this taught for hours and hours. Now the conventional radiology, just get a CT scan, why are you wasting your time? No, that's sad, I'm telling you. It's because the first thing is screening. But now CT scan becoming screening. The ultrasound became screening. IV injection, IV in trauma center is given under the ultrasound guidance.
Yes. Okay. Thank you, sir. Thank you.